this station is to physically demonstrate the assessment and management of the trauma patient. You're being evaluated individually on the skill, but you have an imaginary partner who works under your direction. At the appropriate times, you should describe to me those procedures that you would delegate to your assistant. You may assume you have any needed equipment. For each assessment section, I'll read you a brief patient scenario, and during the assessment, I will answer any questions you would normally ask your patient. Remember, this is a practical exam. You must physically perform the assessment. Do not assume that I can see what you were doing. Briefly tell me what you were doing as you do it. You have 15 minutes to complete each assessment. You'll be stopped at 15 minutes and evaluated on your performance to that point. Please tell me when you're ready to start.
Ready, sir.
Okay. Response will call for a bicyclist struck by a motor vehicle, and on your arrival, you find your patient supine on the ground after being struck by a motor vehicle at a moderate rate of speed.
Okay. Scene safety BSI?
Scene is safe.
Okay, I have one patient, and mechanism of injury is a cyclist struck by a motor vehicle, and this was a cyclist.
Yes.
He's laying supine in the ground. I'm going to direct my partner to take inline immobilization of C-spine.
Okay.
As I approach, what is my general impression? Do I notice any obvious deformity or bleeding, hemorrhage, anything like that?
There is no obvious deformity, and there is no obvious hemorrhage right at the moment.
Okay, so I'm going to approach my patient. Sir, can you hear me? Does he respond as I approach?
No response.
So I'm going to use some painful stimuli. Any response from my patient?
Still no response.
Okay, quick life check. My patient has a pulse.
Patient has a pulse.
Okay.
It's strong and slow.
Strong and slow. And so now I'm going to open the airway with a modified jaw thrust.
Okay.
I'm checking the airway for patency. Is there any need for suction? Do I see fluids,
You
teeth,
can
anything?
hear some gurgling respirations.
Okay, so at this time, suction is going to be needed. I'm going to suction my patient with a Yankauer. We're going to suction no more than 10 to 15 seconds, not losing sight of the distal tip, suctioning on the way out. Does that clear the airway?
The gurgling stops, and your partner has the airway open for you.
Okay, so we now have it open and patent. I'm now going to size and insert my OPA. I'm sizing from the corner of the ear to the tip of the mouth. I'm going to insert at 90 degrees, rotate that OPA until it is inserted and it is flush with the lips. Does my patient accept the OPA?
He does.
Okay, so at this time our airway is secure. I'm going to remove clothing so that I can inspect the chest. As I look at the chest wall, do I notice any deformities, asymmetrical chest rise, flail segments, paradoxical motion,
Your
any
patient
discoloration?
has a part of the left chest that doesn't move at the exact same time as the rest of the chest.
Okay, over the lateral aspect of the thoracic cavity.
Yeah, right along the mid-axillary line.
Okay, so at this time, I've got this kind of paradoxical motion. What is the chest rise, the respiratory rate of my patient?
Patient's breathing about 6 times a minute. It goes from shallow to deep.
Okay, so at this time I'm going to direct my partner to ventilate the patient with the BVM. We're going to attach that to high flow oxygen, 15 liters per minute, and I'm going to direct my partner to ventilate the patient. He's an adult patient, so we're going to deliver 1 breath every 6 seconds just until we see chest rise. Now that we're ventilating the patient, do I notice good chest rise, and do I have okay back compliance by my partner with the BVM?
Back compliance is good, and you have fairly equal chest rise and fall.
Okay, and I'm going to auscultate my lung sounds as I listen over inspiration and expiration with the ventilation of my partner. How are my lung sounds?
A little bit diminished on the left.
Diminished on the left. So at this time I'm saying that this is a paradoxical. We've got a flail segment. So we are internally splinting with our positive pressure ventilation, and we'll apply a bulky dressing to help some external splinting. Does my patient accept the intervention?
He does.
Okay. So at this time my partner's going to continue to ventilate on high flow oxygen, and I'm going to come and I'm going to assess my pulses. So I'm going to compare a carotid and a radial pulse.
Patient has both a carotid and a radial. They're slow and strong.
Slow and strong. Okay. And my skin vitals for this patient?
Skin is pale, but warm and dry.
Okay, pale but warm and dry. All right. And now, anteriorly, we said that there was no gross hemorrhage. Do I notice any signs of bleeding anteriorly on my patient?
You do not.
All right. So I want to check the posterior, so I'm going to use my double glove sweep. So as I come out and I'm checking under the patient, do I notice any glove on my hands as we come through? Any bleeding?
You do not have any gross bleeding.
No gross bleeding on the glove. So at this time, we've done our circulatory check. Our patient's unresponsive. We're ventilating the patient. Concerned about shock. We're going to start to try to warm the patient. We are administering high flow oxygen. Warm the ambulance as we're starting to get ready to get off scene. This patient is high priority. We're going to minimize our scene time and get going. So at this time, I'm going to start up at the head, and I'm going to start my rapid assessment. So at this time, do I notice any major deformity to the head?
You don't, nothing visible.
Okay. And is my patient still accepting my OPA?
Yes.
All right.
The partner's ventilating.
Partner's ventilating, and we still have good back compliance? Okay. As we come down to the neck, do I notice any JVD tracheal deviation?
No JVD or tracheal deviation.
Okay. And when I palpate the back of the neck, do I notice any step-offs?
You do not.
Okay. So at this time, we're going to size and apply a cervical collar. We're going to apply that to bare skin. Does my patient accept my cervical collar?
He does.
Okay. Moving back to the chest, so we're ventilating and we have internal and external splinting for our paradoxical motion. Are those interventions still withholding?
Yes.
And when I reassess my lung sounds, we had diminished on the left. Do I notice any change in my lung sounds?
Still diminished on the left.
Okay. And I have adequate chest rise with ventilation?
Yes.
We're moving down to the abdomen, finding the umbilicus, dividing into 4 quadrants. I'm palpating the abdomen. Do I notice any rigidity, any discoloration, anything that is directing me towards any type of internal bleed?
Abdomen soft and not distended.
Okay. Moving on to the pelvis, I'm going in and down to check for stability of the pelvis. How is the stability of my pelvis?
Pelvis is intact.
Okay. I have a male patient. I'm checking for any signs of priapism for a spinal cord injury.
No priapism.
No priapism. And has he been incontinent of urine feces?
He is incontinent of urine.
He is incontinent of urine. And any bleeding?
No.
None. All right. So as we come down and I circumferentially and offset the femurs, do I notice any deformity, discoloration to my femurs?
Femurs are intact, but as you look down that left leg, you notice that he has an angulated left lower leg fracture.
Angulated. Okay. So at this time, I'm going to check for a pedal pulse. Do I have a present pedal pulse?
Pedal pulse is absent.
Absent pedal pulse. So we're going to take one attempt to put that back in its anatomical position. Did that realign, and do we now have pulses with that realignment?
Leg is realigned, pulses are present, slow, and so on.
Okay, so I'm going to direct my partner to now splint that in place.
Okay.
And we're going to come back up, and what we want to do now is with appropriate personnel, on the headman's count, we're going to log roll the patient towards me so we can check the posterior.
Okay. Patient, would you roll onto your left side, please?
Okay. So as we come down, we check the back of the head. We got the collar in place.
Okay, as you palp the back of the head, you notice that the patient has crepitus and a hematoma to the occiput.
Okay, so we're going to apply some bulky trauma dressing, have that in place, and this is to put some padding so when we put them on the longboard, we're not causing. My collar is still in play as I palpate down the vertebrae. Do I notice any step-offs or deformity?
His spine appears to be intact.
Okay, and you said my patient was incontinent, so we would remove any wet clothing, making sure that we're warming the patient and treating for shock, and at this time, any other deformities that we know?
No.
Okay, so our longboard is in place, so on the headman's count, on the count of 3, we would log our patient onto the longboard.
Okay.
Okay. Once they're on the longboard, we will immobilize with straps and head blocks, and once our patient is appropriately immobilized on the longboard, we're going to start to load them in the back of the ambulance. While we're loading up, are we able to obtain any type of sample history?
No sample history available.
Okay, so we're now in the ambulance. All of our interventions and assessments at this time are going to be en route to the hospital, and I would like to get a baseline set of vitals. So my partner is controlling ventilations with the BVM. Do I still have good bag compliance?
Still good bag compliance. If your partner stops ventilating, his respiratory rate goes down about 4.
Okay, and when we reassess those lung sounds, they were diminished on the left. Are they still diminished?
Still diminished on the left, but they're no worse.
No worse, okay. And all of our interventions are still withholding?
Yes.
Okay. We reassess our carotid and radial pulse. Has there been any change to our pulses?
His pulse is slow, strong, and the rate is about 50.
Okay. We've got all of our bleeding controlled. We've got a blood pressure?
His blood pressure is 190 over 110.
Okay. Based on the crepitus to the back of the head, the blood pressure, we're now concerned that the patient has a head bleed. So at this time, we want to make sure that we're doing a good job with ventilation, maximizing our oxygenation. We're treating this patient for shock. And now we're going to start with that rapid trauma assessment. We're going to do our head-to-toe assessment, reassessing injuries and interventions, vital signs every 5 minutes, taking them to a level 1 trauma center where we'll transfer care to an equal or higher healthcare provider.
Okay, thank you.